Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 314 of our pharmacotherapy series, which majors in hypertensive crisis. The first question relates to patient MSR from part 313 of this pharmacotherapy series. Should MSR be given a diuretic before nitroprusside therapy is begun? Administration of potent IV diuretics is relatively ineffective in the acute treatment of hypertensive crisis except in patients with concomitant volume overload or heart failure. Many patients with hypertensive emergencies are vasoconstricted and have normal or reduced plasma volumes, therefore, diuretics have little effect and may actually aggravate renal impairment or cause other adverse effects. Furthermore, when diuretics are given acutely in combination with other antihypertensive agents, profound hypotension can occur. The immediate value of diuretics in acute heart failure is related more to their hemodynamic effects, venodilation, than to diuresis. Venodilation after IV diuretic administration decreases right-sided cardiac filling pressures, decreases pulmonary artery and wedge pressures, and increases cardiac output before diuresis occurs. The presence of heart failure and severely elevated BP in MSR warrants IV administration of a loop diuretic, e.g., furosemide 40 mg, torsemide, Demodex 10 to 20 mg, or bumetanide marketed as Bumex 1 mg. The next question reads, what dose of nitroprusside should be used initially? Effective infusion rates range from 0.25 to 10 micrograms per kilogram per minute. For MSR, an infusion of nitroprusside should be initiated at a rate of 0.25 micrograms per kilogram per minute. The dose should be increased slowly by 0.25 micrograms per kilogram per minute every 5 minutes until the desired pressure is achieved. A maximum infusion rate of 10 micrograms per kilogram per minute has been recommended. If adequate BP reduction is not achieved within 10 minutes after maximal dose infusion, nitroprusside should be discontinued. The dosage must be individualized according to patient response using continuous intraarterial BP recording and observing for signs or symptoms of toxicity. Nitroprusside decomposes on exposure to light, so the solution should be shielded with an opaque sleeve. It is not necessary to protect the tubing from light. Reconstituted solutions are stable for 24 hours at room temperature. A change in the solution's color from light brown to dark brown, green, orange, or blue indicates a loss in activity. The solution should be discarded if this change occurs. The next question reads, a nitroprusside infusion is started. What is the goal of therapy? For most patients, BP should be reduced by no more than 25% within the first minutes to hour, then if stable, therapy can be titrated to achieve a goal BP of 160 systolic 100 diastolic during the next 2 to 6 hours. BPs can be reduced to near normal levels within 8 to 24 hours. However, because MSR has cerebral occlusive disease, that is carotid bruits, excessive reduction of his BP should be avoided. Overly aggressive reduction of BP in the presence of major cerebral vessel stenosis may decrease cerebral blood flow and produce strokes or other neurologic complications. Normal cerebral blood flow remains relatively constant over a wide range of systemic BP measurements through autoregulatory mechanisms. The autoregulatory effects can prevent large alterations in cerebral blood flow from either slow or rapid changes in systemic arterial pressures. In addition, the arterial BP required to maintain cerebral perfusion is higher in hypertensive patients than in normotensive individuals. If MSR's BP is reduced excessively, cerebral blood flow may decrease sharply. Therefore, a diastolic blood pressure of 100 to 105 mm of mercury would be a reasonable initial therapeutic goal for him in the first 6 hours. If hypotension occurs, nitroprusside should be discontinued and MSR should be placed in the Trendelenburg position, in which the head is kept lower than the trunk. The next question reads, MSR is being treated with nitroprusside. However, during the last 36 hours, dose titration to 7 micrograms per kilogram per minute has been necessary to control his BP. His tachycardia angina have resolved. Is he at risk of developing cyanide toxicity? What indices of toxicity should be monitored? Are there agents available to prevent toxicity? A major concern when using sodium nitroprusside is toxicity secondary to the accumulation of its metabolic byproducts, cyanide, and thiocyanate. Sodium nitroprusside decomposes within a few minutes after IV infusion. Free cyanide, which represents 44% of nitroprusside by weight, is released into the bloodstream, producing prussic acid, that is hydrogen cyanide, which is responsible for the acute toxicity. The amount of hydrogen cyanide released is dose-related. Endogenous detoxification of cyanide occurs through a mitochondrial rhodonase system, which, in the presence of a sulfur donor such as thiosulfate, converts cyanide to thiocyanate. Theoretically, cyanide can be expected to accumulate in the body when the rate of the sodium nitroprusside infusion exceeds 2 micrograms per kilogram per minute for a prolonged period. The presence of hepatic or renal impairment may also predispose the patient to cyanide toxicity. Symptomatic cyanide toxicity occurs infrequently, however, several deaths have been reported after the use of sodium nitroprusside. Cyanide toxicity occurs most commonly when large doses, that is total dose 1.5 mg per kilogram, of nitroprusside are administered rapidly to patients undergoing a surgical procedure that requires induction of hypotension. However, cyanide toxicity and mortality associated with nitroprusside exceed 3,000 and 1,000 cases per year, respectively, according to 2 sources. Although concurrent sodium thiosulfate administration has been recommended in high-risk patients, no clinical data are available to indicate that it reduces overall mortality. Furthermore, this intervention may result in the accumulation of thiocyanate, particularly if sodium thiosulfate is given at high infusion rates or to patients with renal insufficiency. Hydroxycobalamin has also been used to reduce the risk of cyanide toxicity secondary to nitroprusside infusions, but its use is limited because of poor availability and cost considerations. With the availability of safer alternatives, e.g., phenyldopam, IV labetalol, IV nicardipine, for use in high-risk patients, the use of hydroxycobalamin or thiosulfate is rarely required. Cyanide toxicity can be detected early by monitoring MSR's metabolic status. Lactic acidosis is an early indicator of toxicity because the progressive inactivation of cytochrome oxidase by cyanide results in increased anaerobic glycolysis. A low plasma bicarbonate concentration and low pH, accompanied by an increase in the blood lactate or lactate to pyruvate ratio, could indicate cyanide toxicity. Additional signs of cyanide intoxication include tachycardia, altered consciousness, coma, convulsions, and the occasional smell of almonds on the breath. Measuring serum thiocyanate levels is of no value in detecting the onset of cyanide toxicity. If toxicity develops, the infusion should be stopped and appropriate therapy for cyanide intoxication instituted. The need for such a high-dose infusion of nitroprusside to maintain MSR's pressure may increase his risk for cyanide toxicity, warranting close monitoring of his acid-base balance. The next question reads, explain the difference between cyanide toxicity and thiocyanate toxicity. What is MSR's risk for thiocyanate toxicity if he is continued on a dose of 7 micrograms per kilogram per minute? Is monitoring of serum thiocyanate concentrations necessary? Sodium nitroprusside is more likely to produce thiocyanate toxicity. Although this complication is also rare, patients with renal impairment who receive infusions beyond 72 hours are particularly susceptible. Conversion of cyanide to thiocyanate, via sulfation by the liver, proceeds relatively slowly. The half-life of thiocyanate is 2.7 days with normal renal function and up to 9 days in patients with renal failure. When sodium nitroprusside is infused for several days at moderate dosages, 2 to micrograms per kilogram per minute, toxic levels of thiocyanate can occur within 7 to 14 days in patients with normal renal function and 3 to 6 days in patients with severe renal disease. Thiocyanate causes a neurotoxic syndrome manifested by psychosis, hyperreflexia, confusion, weakness, tinnitus, seizures, and coma. Prolonged exposure to thiocyanate can suppress thyroid function through inhibition of iodine uptake and binding by the thyroid gland. Measurement of blood levels of thiocyanate is only recommended in patients with renal disease or when the duration of the nitroprusside infusion exceeds 3 or 4 days. Nitroprusside should be discontinued if serum thiocyanate levels exceed 10 to 12 mg per deciliter. Life-threatening toxicity is of concern when blood thiocyanate levels exceed 20 mg per deciliter. In emergency cases, thiocyanate can be readily removed by hemodialysis. For MSR, the potential for thiocyanate toxicity is low because his renal function is normal and the anticipated infusion duration is relatively short. Therefore, measurement of thiocyanate levels is not indicated. Other side effects associated with nitroprusside therapy include nausea, vomiting, diaphoresis, nasal stuffiness, muscular twitching, dizziness, and weakness. These effects are usually acute and occur when nitroprusside is administered too rapidly. They can be reversed by decreasing the infusion rate. The next question reads, MSR's serum chemistries and arterial blood gas values indicate a metabolic acidosis. Should the nitroprusside infusion be continued at 7 micrograms per kilogram per minute? What alternatives are available? Although the duration of MSR's nitroprusside therapy has been short, tolerance to the antihypertensive effect requires the use of a high-dose infusion to maintain BP control. Thus, acidosis may represent toxicity as a result of cyanide accumulation. The nitroprusside infusion should be discontinued at this time, and another rapidly acting, easily titratable parenteral antihypertensive such as phenyldopa or IV nicardipine should be initiated. The next question reads, what are the advantages and disadvantages of phenyldopa compared with sodium nitroprusside? Phenyldopa is a parenteral, rapidly acting, peripheral dopamine 1 agonist used to manage hypertensive crisis when a rapid reduction in BP is required. Stimulation of the dopamine 1 receptors vasodilates coronary, renal, mesenteric, and peripheral arteries. Phenyldopa has been used to control perioperative hypertension in patients undergoing cardiac bypass surgery. The use of low-dose phenyldopa had been evaluated in those with acute kidney injury following cardiac surgery. Therapy was not associated with a reduced risk of renal replacement therapy or 30-day mortality. This refutes prior theories that dilation of the renal arteries with phenyldopa may reduce the risk of renal complications. Phenyldopa is as effective as sodium nitroprusside for treatment of hypertensive emergencies and does not cause either cyanide or thiocyanate toxicity. Phenyldopa can be considered as an alternative to nitroprusside in patients who are at high risk for cyanide or thiocyanate toxicity. Over the past several years, the use of phenyldopa as an antihypertensive has decreased. Clearance of phenyldopa is not altered by renal or liver disease. Like nitroprusside, phenyldopa also has a short duration of action, with an elimination half-life of approximately 5 minutes, thus allowing for easy titration. BP and heart rate should be frequently to avoid hypotension and dose-related reflex tachycardia. Flushing and headache may occur. Serum potassium should be monitored and repleted as necessary. Phenyldopa should be used cautiously in patients with glaucoma or intraocular hypertension due to a dose-dependent increase in intraocular pressure. The next question reads, which antihypertensive agents should be avoided in MSR? Why? Labetalol, a potent, rapidly acting antihypertensive with both alpha and beta blocking activity, is very effective in the treatment of hypertensive emergencies, but it should not be used in MSR. Hemodynamically, labetalol reduces peripheral vascular resistance, that is afterload, BP, and heart rate, with almost no change in the resting cardiac output or stroke volume. MSR was experiencing chest pain, and had tachycardia on admission. These signs and symptoms are most likely caused by his severely elevated BP and the presence of acute left ventricular failure. Even though labetalol may have alleviated MSR's angina, the negative inotropic action could acutely compromise his left ventricular dysfunction, an effect that outweighs the potential benefit of afterload reduction. In addition, even though labetalol is one of the safest beta-blocking drugs when used in patients with asthma, beta-blocker therapy should be avoided as initial treatment in patients with asthma. Labetalol should be used only if alternative methods of reducing MSR's pressure fail. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 315.